We will start with Dr. Reem to continue the second part of infectious disease lecture.
Assalamu alaikum. Okay, so the first question for today, a 36-year-old nurse from Malaysia presented to the emergency department with a sudden onset of malaise, fever, headache, retroorbital pain, backache, and myalgias. On examination, her temperature is 39.6 with normal blood pressure and slight tachycardia. He has skeletal injection. Laboratory studies are notable for a platelet of 100,000. Which of the following is about the patient illness is true? Second infection can result in hemorrhagic fever. Infection result in lifelong immunity. Serology is not helpful in the diagnosis. Disease is transmitted by a close contact, and Riyadh is an endemic place. Excellent. If there is a problem, we'll let you know. Thank you very much. Okay, so I see people are between A and C. So let's look that and show the correct answer. Second infection can result in hemorrhagic fever. This should be a very easy question for most of us because we are very familiar with dengue fever. So hemorrhagic fever for the boards, what I want you to focus on is hemorrhagic fever question can be about a patient who is living in Saudi Arabia, whether it's a citizen or not, but somebody who's living in Saudi Arabia. And it could be also a fever in a returning traveler, as we discussed yesterday. So in the context of or in the Saudi Arabia, we will have, inshallah, another slide that explains more about the hemorrhagic fever in the country. But for travel related, the patterns that I would like you to remember, or the patterns that I would like you to keep in your mind, because it could be a potential exam question. Hemorrhagic fever that presents with jaundice and renal failure. This is yellow fever until proven otherwise. And in those cases, they may give you in the question a proteinuria as a clue to the diagnosis. And usually this is for patients who travel to Africa or to the Amazon forest. Dengue fever, as you would expect, it can come as a fever returning traveler, or it can come also as a patient who is living in the kingdom. So I think that probably should be a straightforward question. But the clues in the question, there is no renal dysfunction, there is only mild hepatitis. So if they bring to you a patient with severe hepatitis or liver failure, this is probably not dengue fever. In the second infection or in the second episode, hemorrhage and capillary leak could happen. Fulminant hepatitis B infection can be also another diagnosis that you may need to pay attention to, because it can present as a hemorrhagic fever. Then patients would present with coagulopathies along with their liver dysfunction, and this may be misleading. So it's very important to look into the clues in the question. Leptospirosis, severe icterus, hemorrhagic manifestation are usually not severe. So in a patient, they will bring you a patient who has severe icterus, but their coagulopathy is not that bad. The hyperbilirubinemia liver function test is more than 5 times normal. And it's very important to remember the activities. As we mentioned yesterday, if it is a fever returning traveler, so swimming, kayaking, rafting in contaminated lakes, or in white waters like rivers is one of the major clues in the question. Next question is all is true about Rift Valley fever, except it's a zoonotic viral disease characterized by necrotic hepatitis. Infection is acquired through mosquito bites. Infection can be acquired through contact with tissues of infected animals. And number 5 is human-to-human infection is common. So you can start voting now. So the question is about Rift Valley. Okay. I hope everybody had a chance to vote. So this is the incorrect answer, which is the human-to-human transmission or infection is correct. And this is the slide that I was talking about initially. This is the viral hemorrhagic fevers that is present in the kingdom. So if there is a question about viral hemorrhagic fever for somebody who's living in the kingdom, it's going to be one of those four. And I would assume that one of those three probably the most common. So between dengue, al-Hurma, and Rift Valley fever are probably the most common. So the vector is mosquito, as you know, for the dengue fever. Although I don't think that it's a fair question to ask you about the mosquito name, but it could happen in the internal medicine board. So you need to remember Aedes aegypti for dengue fever. It's for the al-Hurma, it's usually a tick-borne disease. I would not expect anybody to be able to pronounce this. I actually not able to pronounce it myself. I usually need to have time to look at it. And the main focus or the main exposure risk that should be available in the question for you to look or to think of al-Hurma is exposure to livestock. And then for the Rift Valley fever, again, it's a mosquito. Aedes aegypti is one of the mosquitoes that can transmit Rift Valley fever. And again, here, contact with infected or aborted animal tissues, drinking unpasteurized milk in infected area or in endemic area is the most likely exposure risk factor. For the Congo hemorrhagic fever, it's a tick-borne. So you need to remember that two of them are tick-borne, two of them are mosquito vectors. As you can see, the incubation period is pretty short in most of them. The longest incubation period is in the Rift Valley fever, and then you will look into the clinical syndrome. The dengue fever, I think if it's going to come in the exam has, or the question has to emphasize on the point of eye pain, joint pain. The other differential diagnosis that comes with the severe bone pain or eye pain is chikungunya. Chikungunya is not an endemic virus in the kingdom, but we do have some reported cases because it's transmitted by Aedes aegypti. So if a patient got infected abroad and then an Aedes aegypti mosquito has bitten him, this Aedes aegypti could potentially transmit the virus, and that has been reported in Jeddah. Al-Hurma fever starts with a non-specific viral prodromes, followed by generalized malaise and diarrhea, and then there will be a second phase, if you'd like to say, that may appear in some of the patients, and usually that include neurologic and hemorrhagic symptoms in a very severe form. So again, this is another clue that you may get from the question, is the severe neurological manifestation. Rift Valley fever is also well known for its multi-system disease that include encephalitis and hemorrhagic fever. So the question could potentially tell you about a patient who had initially an encephalitis-like symptoms. For example, LP was normal, but now he's progressing and having hemorrhagic fever. So one of the things that you may need to think about is Rift Valley fever, if it is presented in the right context. And Rift Valley fever was actually reported only in Jazan area. So if they give you other areas in Al-Janub or Al-Asir, then probably you should not think of Rift Valley fever. We actually don't have active cases of Rift Valley fever over the past few years. So I don't think it's a hot topic now, and I don't think it should appear in the exam. But again, I'm not really quite sure how Al-Hay'a people think. The Congo hemorrhagic fever, I don't think is going to be an exam question because of its rarity. I don't think we had any active cases in the kingdom for the past several years. Next question, a 23-year-old woman is seen in the emergency department for fever and altered mental status. She's from Jazan and has been in Riyadh to visit her family. She reported 3 days history of episodic fever before leaving home. Over the course of the day, her family described deteriorating mental status. Now she's confused and lethargic. Her physical examination is notable for a temperature of 40, heart rate of 145, systemic blood pressure 105/60. She has clearly gravid uterus, approximately 24 weeks of gestation, and neurological examination shows confusion but no focal finding. A thick and thin blood smear are consistent with the diagnosis of malaria. treatment with IV quinidine is started immediately. Which one of the following are potential complications of therapy? Or hyperthyroidism, hypoglycemia, nightmares, retinopathy, and seizure. And yes, so you can start voting. Okay. So I think we have a nice spread among the different answers, but the correct answer is hypoglycemia. As I mentioned yesterday, malaria, everything about malaria is very important. And I literally mean everything. I'm trying to move the slide. Everything about malaria is very important. I'll go over some very important points that I think you need to pay attention to. But please, from now until the exam, try and know everything about malaria, life cycle, diagnosis, prophylaxis, different regimen for the prophylaxis. Everything potentially about malaria should be at the back of your head. And malaria is a very common exam question, either for the written exam or حتى for the OSCE. So please, be sure you know malaria very well. A 51-year-old woman is diagnosed with Plasmodium falciparum malaria after returning from a safari in Central Africa. Her parasitemia is 6%, Hemocritus 21%, bilirubin 7.8 milligram per deciliter, creatinine 2.7. She's still making 60 ml of urine. She rapidly becomes obtunded. Intensive care is initiated with frequent creatinine checks and close monitoring of the hypoglycemia. Infusion of phenobarb for seizure prevention has started. Mechanical ventilation for airway protection and exchange transfusion to address her hyperparasitemia. Which one of the following regimen is recommended as first-line treatment for her malaria infection? Chloroquine, IV artesunate, IV quinine, IV quinidine, or mefloquine, and you can start voting. Okay. Any more answers? So I agree with the majority of you. The treatment or the first-line treatment for IV artesunate for malaria, falciparum malaria, is IV artesunate. So malaria diagnosis and treatment. Well, you have to know that there is a national guideline. So there is a very frequently updated guidelines for the treatment of malaria in Saudi Arabia. And I would expect if there is an exam question about malaria, it will be driven from this national guideline. So the diagnosis is usually based on the blood film, but also on antigen testing. Antigen testing is available in most of the Ministry of Health hospitals around the kingdom, definitely available in the endemic area. So it's very, very important to know that this could be part of or could be a test for the diagnosis. For the treatment, you will really need to look into it as uncomplicated or complicated malaria. So for the uncomplicated malaria, artesunate with sulfadioxine pyrimethamine should be your first choice. But in cases of severe G6PD or sulfa allergy, we can use artesunate with mefloquine. So mefloquine and artesunate is not the primary or not the first line treatment for the treatment of uncomplicated malaria. But in these cases that I mentioned here, then you could use the second line. For complicated therapy, IV artesunate combination is the treatment of choice. Again, this is available in most of the Ministry of Health hospital around the kingdom. And especially in the endemic area, so this should be your treatment. Addition of long-acting partner agent, whether it's the sulfadioxine or the mefloquine, is important because we really need to maintain the anti-malarial effect. Don't forget, there is a hepatic stage. So after we clear the parasitemia, the hepatic stage could actually release some of the mature trophozoites to the bloodstream, and this actually can lead into recurrence of the malaria. So it's very important that we add another agent. Second line treatment is intramuscular artemether, and the third line is quinine IV. And we really should not use IV quinine there is no availability of the first two lines for therapy. As I mentioned yesterday, malaria or pregnancy has a special consideration in the boards because of the different medications use or classification for safety for use in malaria. And this is again based on the national guideline for uncomplicated malaria in the first trimester, oral quinine and clindamycin for 7 days. As you would expect, primaquine and doxycyclines are contraindicated. In the second and third trimester, artemisinin-based combination are indicated. And then for complicated malaria, regardless of what is the stage, IV artesunate should be used. And this is very important because if there is a life-threatening infection, the priority goes to protecting the mother's life. Next is a 45-year-old Sudanese male patient. Is evaluated for right quadrant pain, fever, and hepatic tenderness. He reports no diarrhea or blood stool. He is found to have large hepatic abscess on CT scan of the abdomen. Of note, he's been in Saudi Arabia for approximately 10 years and was well until approximately 10 days ago. Which of the following tests can be used to confirm the diagnosis? So examination for stool for trophozoites, liver biopsy, PCR for Campylobacter, response to trial of iodine or serologic test for Entamoeba histolytica. Okay. I think the majority of you are going to the correct answer. Okay. So here in this slide, I wanted to summarize to you the differences between pyogenic liver abscess and amoebic liver abscess, because this could be a potential source of confusion for the exam. So pyogenic liver abscess, as you can see on the sides of the screen, pyogenic liver abscess is usually multiple lesions. Amoebic is usually a single solitary lesion. And usually blood cultures will be positive for patients with pyogenic liver abscess. The treatment for pyogenic liver abscess involves a very important step, which is the drainage of the pyogenic liver abscess and then maintaining broad spectrum antibiotic. It depends on the size of the abscess, whether to go for a percutaneous drainage or whether you just give the empirical antimicrobial and then repeat the imaging in later stage. For amoebic liver abscess, the treatment starts with the metronidazole, followed by promomycin to eradicate the amoeba in the intestine. And antibiotics has no role except if there is a secondary bacterial infection. We don't usually send those patients for drainage because they usually respond very nicely to the antimicrobial therapy. Next is a 35-year-old man patient from India who's seen for evaluation for several weeks of fever that has decreased in intensity, now has developed abdominal swelling, no significant past medical history. Physical examination shows palpable splenomegaly and hepatomegaly with diffuse lymphadenopathy. There is a diffuse hyperpigmentation in his skin, and visceral leishmaniasis is suspected. Which of the following is diagnostic? Culture of the peripheral blood for Leishmania species, PCR Leishmania nucleic acid in the peripheral blood, PCR of the hypopigmented area in the skin, smear of stool for a mastigoid, and splenic aspiration to demonstrate the mastigoid. You can start voting. So a splenic aspiration to demonstrate a mastoid is the correct answer. PCR leishmania from the peripheral blood is probably only available in research labs in the kingdom. I'm not aware of any center that has the PCR for leishmania from the peripheral blood. Most of the people will rely on the histopathological finding for the diagnosis of leishmania. Okay. 44-year-old woman presents to the emergency department with recurrent episode of right upper quadrant pain, typically soon after meals. These episodes may have present for the past 1 month and seem to be worsening. The patient is from Asir and has been living in Riyadh for the past 5 years. She takes no medication and is physically active. On physical examination, she is jaundiced and in obvious discomfort because of the right upper quadrant pain. She's afebrile and tachycardic. Her physical examination is notable for large liver. Ultrasound confirmed a large liver, which demonstrated a complex 14 centimeter cyst with daughter cysts extending to the liver edge with associated biliary tract dilatation. Which of the following is the most appropriate management approach to this patient presentation? Albendazole medical therapy, albendazole followed by surgical resection, needle aspiration of the cystic lesion, hair or serological testing for echinococcus. And start voting. Okay, so I think around 50% you got the correct answer, and the reason is because of the size of the cystic lesion. So for echinococcosis, the most commonly affected organ is the liver, but followed by pulmonary manifestation. Please note that pulmonary manifestation is not that uncommon in Saudi Arabia, so actually it is seen quite frequently, sometimes with a liver involvement and sometimes as a solo involvement of the lung. The diagnosis usually relies on radiology and serology. The radiological manifestation is usually quite specific, and the radiologists who are experienced will be able to pick it from the ultrasound or from the CT scan results. Sometimes we need, not sometimes, and most of the time we will do definitely serology to confirm the diagnosis. Surgical resections is recommended for 3 main indications that you may need to be aware of: complex cyst, superficial cyst that has a risk of leakage, and cyst that is involving the biliary system. So it's very important to remember these indications for surgery because, as you saw, it could be the exam question. In general, if none of these are present, the approach or the recommended therapy is albendazole before or after PER. Surgery is usually done, as I mentioned, for specific indication, and it doesn't really matter whether you give before or after. Most of us will prefer to give after the albendazole because sometimes albendazole will help the cyst to shrink in size, will also decrease the risk of spillage of the material and causing anaphylaxis. So most of the ID physician will actually prefer to do repair or surgical intervention after albendazole therapy. Next question, 14-year-old presented to the hospital with 24 hours history of nausea, vomiting, and abdominal cramps. An examination, afebrile, but abdomen is guarding and tenderness. In the ER, she passed large quantity of the material in her stool that you can see on the right-hand side. What is your diagnosis? And I think this should be a spot diagnosis. Okay. يعني I really don't think إنها it will get يعني more straightforward في الexam. And I'm not really sure إنهم they will bring it this way. This is ASCAPS. Okay. 21-year-old medical student present 2 weeks after his return from an elective in Africa with 7 days history of fever and non-productive cough. The family medicine prescribed him amoxicillin 2 days ago. He spent his elective time in Kenya, but he also traveled to Malawi and South Africa. He developed fever with diarrheal illness 2 days before returning back and was given metronidazole by the local physician for the possible diagnosis of amoeba. He reports that his symptoms settled after 3 days. On examination, he's febrile, heart rate at 90, blood pressure 115/60. He has an urticaria rash over his trunk, no lymphadenopathy, abdomen was soft with tenderness over the left hypochondrium, and the tip of the spleen was palpable. This is his laboratory investigation: hemoglobin 14, white blood cell 9.3, neutrophil 5.3, lymphocytes 1.5. Monocytes 0.1, and as you can see highlighted in red, eosinophils 1.4, platelet 350, chest X-ray, and amoeba serology are both negative. So what is your most likely diagnosis? Amoeba, HIV seroconversion, schistosomiasis, trypanosomiasis, or typhoid fever? Okay. So the correct answer is schistosoma. 24-year-old male patient, medically free, presents to the clinic with hematuria. For the past 2 days, he's been passing bright red blood at the end of maturation. He has mild dysuria, no fever or abdominal pain. His social history is notable for travel to Central Africa 3 months ago with camping and water rafting. He reports having unprotected sex with multiple partners during his trip. He works as an engineer. His temperature is 36.1, blood pressure 120/70, heart rate 68. Abdomen is soft and tender with no organomegaly. The external genitalia are unremarkable. On rectal examination, the prostate is normal in size and non-tender. The laboratory results showed a hemoglobin 12.9, platelet 180, white blood cell 13,000, mostly neutrophil, but has a eosinophils of 9%. Lymphocyte 24% and monocyte 2%. BUN creatinine normal, and urinalysis showed moderate blood, leukostrate positive, nitrate negative, bacteria none, 10 to 20 per high power field white blood cell, and many RBCs per high power field, and no casts. What is the next best step in this patient management? CT abdomen and pelvis, cystoscopy, peripheral blood morphology, cystosoma serology, or tuberculosis skin test. What do you think? آخر كلام عشان نشوف. Okay. Before I move from this slide, whoever chose peripheral blood morphology for malaria, malaria does not come with eosinophilia. So if you see in the exam, in the question, eosinophilia, please don't choose malaria or don't think of malaria because it's not going to be malaria. So here, the diagnosis could be potentially be given by the schistosoma serology given the duration of the patient's symptomatology. Okay, next slide, please. A person with liver disease caused by schistosoma mannsoni would be most likely to have what condition? Ascites, esophageal varices, gynecomastia, jaundice, or spider? You can vote. So schistosoma is very well known to cause periportal fibrosis, and that's usually result in portal hypertension without the other signs of chronic liver disease. So those patients are expected to have signs of portal hypertension, but not, or complication of portal hypertension, but not other signs of chronic liver disease. Next slide, please. Okay. So for schistosomiasis, I brought you different clinical syndromes, and the answer is still schistosomiasis because this is very important. Again, schistosoma is one of the endemic diseases in the kingdom, and again, I think it is very important that we test the internist ability to define or to look into different clinical syndrome. So for acute presentation for schistosomiasis, it can be Katayama fever, which is usually presents as fever, urticaria, angioedema, chills, myalgia, abdominal pain. This is usually a self-limiting disease. If you catch the patient during the enlargement of the organomegaly or the lymphadenopathy, then it can be tender on examination. And there is for sure a peripheral eosinophilia. So if the question tells you that the patient has tender hepatosplenomegaly, has eosinophilia, and has some of these manifestations in the acute presentation, then probably you should think of schistosoma. For chronic schistosomiasis, that would require repeated exposure, and usually the pathology is related to the species. And it's very important to recognize in hematopium is mostly a urinary tract infection, and Mansoni is a liver disease. And these are the two most important species because these are the species that are commonly seen here in the kingdom. The treatment is praziquantel. And as you can see here, I put all the three species. And as I mentioned, Mansoni and hematopium are the most common species that we are seeing here in the kingdom or the other parts of the Middle East. The hematopium can cause urinary schistosomiasis. The other two can cause hepatic schistosomiasis. Fine. Next is a 45-year-old male patient referred to the hospital for workup of pancytopenia. On arrival, he's febrile, tachycardic, stable blood pressure. He looked sick and diaphoretic. You sent for a septic screen and peripheral blood film and started him on broad spectrum antibiotic. Chest X-ray is clear. 4 days later, his blood culture grew gram-positive coccobacilli. What is the most likely diagnosis? So is it Listeria monocytogenes, Burkholderia milli, pneumococcal pneumonia, Brucella species, or Haemophilus influenza? You can vote. Okay. So as you predicted correctly, this is a Brucella species. طبعا Listeria is not a coccobacillus, it's a gram-positive roads, Burkholderia gram-negative roads, pneumococcal gram-positive diplococci. Haemophilus is the other one that is coccobacilli, but the clinical syndrome does not fit that. Can you move the slide, please? What is the most appropriate treatment for the above mentioned patients? Ceftriaxone, vancomycin 2 weeks, ampicillin 3 weeks, meropenem and Bactrim 4 weeks, streptomycin for 14 to 21 days, plus doxycycline or meropenem until final identification is available. Okay, should I look it now? Or do you want more time to think? Okay, excellent. Doxy and streptomycin. So for brucellosis, it's also another endemic infection in the kingdom, but I wouldn't think it's as important as malaria. The reason is malaria is a life-threatening infection and usually can kill the patient. So it's very important for internists to be able to diagnose malaria. So for brucellosis, the definition of complicated and uncomplicated brucellosis depends on the involvement of end organs. So uncomplicated, that is usually presents with the classical manifestation of brucellosis with arthralgias. Complicated is when there is an involvement of osteoarticular involvement, genitourinary, neurological, cardiovascular, or if there is other manifestation like pulmonary, ocular, and dermatology. The common laboratory finding is cytopenia and mild elevation of the liver function test. I remember a patient a few years ago who was referred to our hematology colleagues because of fever and persistent cytopenia with an initial diagnosis of leukemia, and it turned out to be brucellosis. The diagnosis is based on the cultures and also based on the serology. Our cutoff here in the kingdom is 640 because we are an endemic country. If you have a high IgM and low IgG, then the diagnosis is consistent with either an acute brucellosis or previously treated. So you really need to fit it into the proper clinical syndrome. And if both are elevated, it does reflect active disease and require treatment. And also don't forget the proson phenomena. So you really need to make sure that your lab tests and actually corrects for the possibility of proson phenomena if you really suspect brucellosis in your patient. The treatment, so for non-pregnant ladies, and this is, as you can see, it's from up to date, but this is very important. Non-pregnant females with uncomplicated, or in general adults with uncomplicated brucellosis, we give doxycycline plus streptomycin 14 to 21 days, or gentamicin. Gentamicin shorter duration, 7 to 10 days, but most of the clinical studies that was done on the brucella was using streptomycin. The gentamicin was extrapolation and was done in some small series of case studies, and that's why it is now considered an alternative. Mesothel gentamicin is the ability in most of the hospital to measure the level. Rifampicin has also been put as one of the options for first line management with the doxycycline. I usually try to avoid rifampicin for the treatment of brucellosis in the country because we are also an endemic country for tuberculosis. So it's very important that we keep rifampicin for TB. For organ involvement, if there is an osteoarticular joint involvement, then we add a third agent, either rifampicin or Bactrim, and we also extend the duration. For CNS brucellosis, whether it's brucella caused with a space-occupying lesion or without a space-occupying lesion, we usually treat for quite long time, 3 to 6 months, and the initial treatment duration is usually involves an IV ceftriaxone or rifampicin. For cardiac, especially if we are talking about brucella endocarditis, then as you would expect, this is a very serious diagnosis. We always need a third agent, and we always need a surgical evaluation. All the cases reported in the literature did actually report success with both medical and surgical treatment. I think 1 or 2 case reports were successfully treated by medical therapy alone, and those patients had a native valve brucella endocarditis. I have a patient with prosthetic valve endocarditis and brucellosis, and she's on lifelong suppressive therapy because she had 3-do mitral valve, and the surgeon said no more. Pregnancy, for the non-focal disease, we use Bactrim and rifampicin. For focal illness, we use ceftriaxone in addition to Bactrim and rifampicin for the duration of the disease. So whether it's 6 weeks or 3 months or 6 months, depending on the locality of the clinical syndrome. 45-year-old male patient presents with persistent cough, fever, night sweats, and weight loss that has continued for nearly a year. Occasionally, he has a sputum that is tinged with with blood. He has a past medical history of smoking for 20 years. On examination, he is emaciated, BMI is 17, temperature 37.4, chest examinations are remarkable. Which of the following would be the least useful initial investigation in this setting? HIV serology, sputum culture for acid fast bacilli, quantiferon, chest X-ray, or MTB PCR. Awesome. Thank you all for choosing the quantiferon. If you are going, or if your intention is to diagnose active TB, then you should not order quantiferon. Has absolutely no value in the diagnosis of active tuberculosis. You would need to diagnose the disease. You will need pathology, and you will need microbiology results, number one, or pathology that is supporting. Microbiology cultures, PCRs, stains, but quantiferon has absolutely no benefits for the diagnosis of active TB. 32-year-old radiographer present with 3 weeks history of fever, cough, night sweats, and weight loss. Chest X-ray showed an infiltrate with cavities in both upper zone. What is the most appropriate course of action? Re-evaluate him after 7 days and give him levo now. Sputum for AFB and mycobacterial culture. Reassure him and give him OPD after 4 weeks. Give him expectorant and antibiotics for symptomatic release, or do CT chest and abdominal pelvis. Okay, excellent. So this is a healthcare worker, has a classical presentation for tuberculosis, and is also presenting with symptoms suggestive of TB, and has classical radiological manifestation. 26-year-old pregnant lady presents with productive cough, fever, and weight loss. Sputum AFB is positive. What is the best course of action for this patient management? Start INH rifampicin ethambutol 2 months, followed by 5 months of INH and rifampicin. Start the INH rifampicin pyrazinamide streptomycin for 2 months, followed by 4 months of INH rifampicin. Start the 4 for 2 months, followed by 6 months of INH rifampicin. Start the 4 for 3 months, followed by 6 months of INH rifampicin, or just give her the second line as the first line after atropine. Okay. Okay. So we'll give 3 medication for 2 months and then 5 medication for the rest of the duration. I'll have more slides on that. 33-year-old male patient present with fever, abdominal pain for 3 weeks. Normally is in excellent health, but has been feeling increasingly fatigued since returning from a summer vacation in Egypt, where he learned to make traditional cheese. On examination, there is a generalized abdominal tenderness. Peritoneal biopsy was positive for AFB. cultures is also positive for acid fast bacilli that is identified by the gene probe as Mycobacterium tuberculosis. He was started on the 4 medication, but 3 weeks later, the lab reported to you that this isolate is resistant to pyrazinamide, but sensitive to the others. What is the likely source of infection for this patient? Unpasteurized milk, inhalation, exposure to infected human, eating undercooked meat, or reactivation of a childhood infection. Well, I think this as easy as it could get, because I think if they give more information, it will give the correct answer. This is Mycobacterium bovis, which is one of the organisms within the Mycobacterium TB complex. So that's why the probe was positive for Mycobacterium tuberculosis. And the classical finding of Mycobacterium bovis is is pyrazinamide resistance, and that is usually acquired via unpasteurized milk ingestion. A 30-year-old Indian housemaid is admitted with 3 weeks history of productive cough, fever, weight loss, and night sweats. Chest X-ray showed bilateral apical cavitation, and sputum smear was positive for AFB. She was treated for pulmonary tuberculosis 4 years ago, but full details are not available to you at the time of seeing her. There is no other past medical history. She was started on the 4 medication, discharged home, reviewed in the clinic 4 weeks later with excellent adherence to her medication, but continued to have significant fever and cough and additional loss of 2 kg. So what is your most likely explanation? Slow acetylator, HIV co-infection, resistance, non-tuberculous mycobacteria, or paradoxical reaction. Okay. So I agree with the majority of you who chose drug-resistant TB, and I see the around third of the participants voted for paradoxical reaction. Usually with paradoxical reaction, the patient will not lose more weight. They will be on the right direction. They may improve initially and then have worsening. But this patient actually did not improve at all, and she had lost additional 2 weeks, additional 2 kgs after starting her anti-TB medication. And the other thing that is very important to do in the question is that this patient had a history of treated tuberculosis 4 years ago, and the patient is from India, so she does have classical risk factors for TB resistance. So next, when prescribed for patient with tuberculosis, renal adjustment is required for which of the following medication? PZA, inotropam, Moxie, or none of them? Actually, PZA requires renal adjustment. 30-year-old housewife is on quadruple anti-TB therapy for TB lymphadenitis. Which of those adverse effects is not associated with the paired agent? INH with peripheral neuropathy, PZA with hepatotoxicity, rifampicin with hypersensitivity reaction, ethambutol with arthralgia, Moxie with QTC prolongation. Okay, excellent. Oh, so some people have changed their mind. The question is asking you which of the following is not paired with the correct agent, يعني not correctly paired with the correct agent. INH classical risk factor or classical side effect is peripheral neuropathy, and that's why we give vitamin B6. Rifampicin, also one of the classical side effects is hypersensitivity reaction and idiosyncratic reaction. So the classical side effects with ethambutol is actually visual changes and optic nerve changes. 27-year-old male patient with end-stage renal failure on long-term hemodialysis undergoes assessment prior to the living renal transplantation. Tuberculin skin test is 10 millimeter. Chest X-rays are remarkable. CT showed enlarged axillary and mediastinal lymph node. Which one of the following would you do, or what is of the following is correct? So, patient has latent TB and should be started on INH chemoprophylaxis. The donor should have tuberculin skin test and CT chest, abdomen, and pelvis. The patient should be referred for excisional lymph node biopsy prior to the transplant. Transplantation is permanently contraindicated. Patient can proceed for transplant and workup can be done later. So a patient who has a positive quantiferon or a positive PPD, and then the number one rule is you have to rule out active disease. Regardless, symptomatic, asymptomatic, has cough, do not have cough. You should not say that. Rule out active infection. And the first thing that you should do, chest X-ray. If there is enough history of exposure or enough risk factor, for example, this patient is an end-stage renal disease and hemodialysis, then we should do more testing. For example, here the CT scan was done. If a patient has any signs, audiological signs or clinical signs, for example, of active tuberculosis, then this patient should not be started on chemoprophylaxis alone, because this is a risk factor for resistance. And you should send those patients for workup for active tuberculosis. So here it should be an excisional lymph node biopsy. 27-year-old previously healthy woman diagnosed with community-acquired pneumonia and received ceftriaxone followed by oral augmentin with good response. 3 weeks later, Mycobacterium gordani is isolated from the mycobacterial culture of her sputum. What is the best course of action for this patient? Initiate clarithromycin, rifampicin, and ethambutol. Initiate INH and ethambutol. Initiate INH, rifampicin, pyrazinamide, ethambutol. Repeat chest X-ray and sputum culture. HIV serology. Okay. So this question is testing your knowledge about the non-tuberculous mycobacteria. I wouldn't expect you to know the different non-tuberculous mycobacteria and which one is more clinically important and which one is less clinically important. This is not the point. This is not what I'm asking you to do. What I'm asking you to do is to be familiar with the ATS clinical criteria for diagnosis of non-tuberculous mycobacteria. So this patient had an alternative diagnosis, which is pneumonia. She responded to the treatment of the alternative diagnosis, and she has only one sputum culture positive for non-tuberculous mycobacteria. So none of the clinical manifestation presented here to you actually tells you that this patient has an active disease. So there is no urgency to initiate treatment. What we need to do to make sure that we're not missing a patient with non-tuberculous mycobacteria, and you can remove Mycobacterium gordani and put any other non-tuberculous mycobacteria in the question, the answer will still be the same. Even if I tell you this is like Mycobacterium abscesses, you will still need to do the same. Repeat a chest X-ray or repeat chest imaging and sputum culture. Now, for infectious disease physician or for pulmonologists, there are certain non-tuberculous mycobacteria that make us be alarmed. For example, the Mycobacterium abscessus. But for an internist, this is what I want you to know. If you encounter this organism, please know that there is a certain criteria for diagnosis. Having one sputum culture is not diagnostic, and we really need to either repeat the sputum culture, do the radiology, or if there is something in the radiology and the patient is not able to give you a sputum culture, then you need to send those patients for a deeper specimen, like doing BAL. And these are the clinical or the criteria that I was telling you about. So there is a clinical criteria, pulmonary or systemic symptoms, radiological criteria, and you really need both to be able to say that you have the clinical radiological manifestation, and you really need to exclude other diagnoses. And then, as you can see here, the microbiological criteria, if it is sputum, then it has to be two sputum samples that are positive. If it's BAL, then we need one. Or if it is transbronchial biopsy, then with that we will need one sputum culture or brushing to give the diagnosis. Let's finish just a second, because I think we have all to go on tray. احنا في الرياض تقريبا نقرب عندنا العشاء كمان. A few more questions and then we'll go for a break. An Indian man is referred to with the peripheral edema of the arms and recurrent rhinitis. On examination, there is a deformity over the nose and a collapse of the nasal bridge with multiple skin flags. Skin biopsy reveals multiple acid-fast bacilli. What is your most likely diagnosis? Tertiary syphilis, tuberculoid leprosy, atypical mycobacterial infection, nephromatous leprosy, or nocardiosis. If it is syphilis, I wouldn't have given you AFB positive. So syphilis should not be an answer. I know it can cause nasal bridge destruction, but here we're giving you another clue. I think the confusion will be between the three, tuberculoid, atypical mycobacterial infection, nephromatous leprosy, nocardiosis. This is not a clinical syndrome of nocardiosis. Nocardiosis, if it's going to come in the exam, it will be pulmonary sinus manifestation. So for atypical mycobacterial infection, it is not very typical to have destruction of the nasal septum. So it's most likely a leprosy, whether it's the nephromatous leprosy or the tuberculoid leprosy sorry, this is not correct. It's not nocardiosis, it's nephromatous leprosy. So this is another, please correct that. And if you have the recording, it is the nephromatous leprosy, not the nocardiosis. So what will give you the diagnosis between the two forms is how much of acid-fast bacilli is present. For tuberculoid disease or tuberculoid leprosy, it is called POSI bacilli, so that the bacilli will be minimal number. While for the nephromatous leprosy, you will have plenty of acid-fast bacilli present in the tissue or in the acid or in the culture if it is sent for culture. A 36-year-old man is found to have 17 millimeter reaction to the tuberculin skin test as a pre-employment screening. He's from Pakistan and was working in Saudi Arabia for the past 6 months. He reports feeling well. He has no fever, cough, weight loss. Physical examination is normal. The next best step in the management is sputum for acid-fast bacilli, initiate INH prophylaxis, chest X-ray, interferon gamma, or it is related to his BCG vaccination and should not do anything. Please, thank you. So I hope I stressed this enough. Any patient especially coming from an endemic area with positive screening for latent tuberculosis, please, please, please rule out active TB, even in the absence of any symptom that would suggest tuberculosis. Believe me, surprises do happen with TB. So PPD skin test and the risk for reactivation, which is the 5 millimeter, 10 millimeter, 15 millimeter, is very important. Please remember them. And this will be a very easy question, and it's really a shame that you miss it because you did not memorize that. Positive PPD or quantiferon needs chest X-ray to be done even in the absence of symptoms. So I hope I stressed this enough. First line drugs with their side effects is very important for you in the exam, very important for the written exam, very important for the OSCE exam. So you really need to remember those. The duration of therapy for pulmonary and pleural disease, if it is non-cavitary region, we usually give 6 months. Other syndromes, if it is a cavitary, we give 9 months. And the other clinical syndrome, we usually extend it between 9 and 12 months. A risk factor for resistant TB, prior therapy, where the patient is coming from, and non-compliance are extremely important to identify patients with risk for resistant tuberculosis. Here I just put what will you do for patients who developed hepatitis, because I did not give any questions about that, who developed hepatitis because of the anti-TB. So as you can see here in this slide, and you will have the handout so you can look at it carefully, but they divide it into cytolytic or cholestatic hepatitis, and hepatitic hepatitis, and the limits of the elevation of the liver enzymes, and what should you do, and how would you reintroduce the anti-TB. I don't think this will be an exam question for the written exam, probably, although I think it's a bit complicated for internists, but probably could be something that they will ask you about in the OSCE, but not in the written exam. But I think it's very useful to have this information in hand. So we will have, if you don't mind, we'll have a 10-minute break. We need to pray. طيب, let's move on to the. We can start, صح?
Yes, Doctor, sure.
35-year-old HIV infected patients on antiretroviral medication presents with lethargy and myalgia. The blood results showed a hemoglobin of 80, MCV 106, and a white blood cell of 3, platelet 70, CD4 count 200. Which one of the following antiretroviral medication is likely responsible for the abnormal blood test? So is it AZT, abacavir, efavirenz, fosamaprevir, or atazanavir? So the abnormal blood was 1, pancytopenia, 2nd, endomacrocytosis. Classical for, as the majority of you has responded, classical for AZT toxicity. Not toxicity, AZT effect. 45-year-old taking, again, antiretroviral for the last 4 years, presents complaining of swelling of his breasts with some tenderness. Otherwise doing well. Which of the following medication will probably be the one responsible? AZT, raltegravir, efavirenz, lopinavir, and atazanavir. Although this is not one of the very common side effects that we've seen, but it is quite characteristic for efavirenz. So here in this table, I summarize for you what I think is the most likely combination of antiretroviral and a side effect that the board may test you on. I truly believe this is unfair. The antiretroviral medication is a specialized medicine and should be only for infectious disease board. But again, things or surprises do happen to medicine board. So bone marrow suppression, the most important one is AZT, bone marrow density effect is tenofovir, cardiac conduction defect is efavirenz and rilpivirine. You can go later and look into this table and in more details and with more concentration. But I truly try to put everything that I think is testable for internal medicine board in this table. So I'm hoping that you don't need to go back and look into other side effects for the antiretroviral medication. But I just wanted to point out to the bone marrow suppression here, to the bone marrow density, hypersensitivity with abacavir, and the importance of doing the HLA typing before starting abacavir is very important. HIV positive person present to the emergency room with 10 days history of shortness of breath on exertion and dry cough. He admits frequently forgetting to take his medication. CD4 count is 120. On examination, his temperature is 38.5, O2 saturation is 97, and his pulse is 100. His chest is clear auscultation, cardiovascular examination is normal, and chest X-ray shows clear lung field. What is the most appropriate next step? D-dimer, exercise oximetry, high resolution CT scan, bronch, ولا follow up in 2 weeks. I think probably if any of you is now in the emergency room seeing this patient, I would think the majority of you will do exercise oximeter to see whether he drops his saturation or not. Then his presentation could be suggestive of PJP. We know in PJP chest X-ray can be initially normal. And here the question asks you, what can you do as an immediate investigation? You cannot do bronchoscopy immediately. High resolution CT scan will need an arrangement. Like you can ask the patient to walk and check their saturation while they are walking. So in pulmonary infection in HIV and in infection in HIV in general, you could divide them into infections that is related to opportunistic infection, and here it will be related to the CD4 count, and you really need to tease out what is the clinical syndrome, so CNS, pulmonary, skin, etc., and what is the CD4 count, so you can just connect the dots. Or it could be infections that is seen in the general population, and probably the HIV is just a red herring. So please pay attention to that. So if we took, in particular, pulmonary infection, the most important thing that you have to look for is the CD4 infection. So bacterial pneumonia and tuberculosis can occur at any CD4 count. Please remember, pneumococcal pneumonia and tuberculosis are more common in HIV patients compared with the general population. So the exam could be an HIV patient that can have antiretroviral, controlled CD4 count, virologically suppressed. Yet they are presenting with community-acquired pneumonia or presenting with tuberculosis. So this is very important. And I think if they are going to give you TB, I hope so, they should give you a normal CD4 count so they could direct your thinking towards tuberculosis. And don't forget, common is common, so streptococcal pneumonia is the commonest. PJP, disseminated fungal disease, CMV, always occur at low CD4 count, so below 200. And this table is from UpToDate that give you the radiological manifestation seen on the CT scan and what could that be translated into from an infection point of view in HIV patients. Next, 39-year-old man presents with or tested positive for HIV in a premarital screening. The patient has been feeling well. He works as a nurse in the local hospital. He owns 2 pets at home. All of them are healthy. Vital signs are normal. Examination shows no abnormality. Laboratory testing reveals the following. HIV antibody positive, RNA quantification is 600 1000 ml. CD4 count is 730. Antiretroviral therapy is planned. The patient is at greatest risk for infection with which of the following organisms at this point of time? Cryptococcus neoformans, Histoplasma capsulatum, Mycobacterium tuberculosis, PJP, or Toxoplasma. You can vote now. So this is a question that is truly يعني whether you know it or you don't know. هنا نعطيكم patient who is probably seroconverted والدليل انه يعني his viral load is very high لكن his CD4 count is still maintained. So whether this is acute or subacute, at least يعني I would say it's an early HIV infection. Has a normal CD4 count and is asking you, with this CD4 count, which infection do you think is this patient at greatest risk for? And I think I just mentioned it, that tuberculosis does not respect or does not consider CD4 count. So tuberculosis is the correct diagnosis. So here in this table, you would see the infection with what is the CD4 count limit that we usually see this infection at. PJP less than 200, Toxoplasma less than 100. So for those who chose toxoplasmosis, it wouldn't manifest at this time. MAC less than 50, Histoplasma capsulatum less than 150, and this is usually an endemic area. We are not by any means an endemic area for Histoplasma. VZV has nothing really to do with the CD4 count. Like in one of the HIV presenting or one of the AIDS defining criteria is recurrent VZV infection. So it's very, very important to remember that even in the presence of a normal CD4 count, all HIV patient is at higher risk for tuberculosis compared with the general population اللي عندهم normal CD4 count. For patient in the previous question, what will be the best ART combination to start? And here is the combination: Atripla, Biktarvy, Darunavir, Ritonavir, Truvada, AZT with Atripla, AZT, GDI, and Atravirine. And I truly believe, this is an unfair question. I 100% agree with that. لكن it's just an entrance to word antiretroviral medication. So I'm not going to take a long time in this لأنه I truly believe you should not know antiretroviral medication by heart. But one of the years when I was giving the MCQ sessions للboard review, قالوا لي إنه one of the years they actually asked them what antiretroviral medication, which is totally unfair. Now the international guidelines all suggest this combination of antiretroviral medication. I truly believe this is an unfair question. This is highly specialized medicine. It is evolving, it is changing, and I don't think they should ask about specific medication. Well, they can ask you, when should you refer those patients to ID? What initial tests should you do? يعني عشان risk for a sexually transmitted disease and you really need to treat them because they may have other partners. يعني things that is more relevant to the internist. But يعني it did actually happen before, and that's why I brought this question. These are the different classes of antiretroviral medication. Now, the protease inhibitor are the backbone of the antiretroviral medication with the combination of two other medication. There are also now the dual therapy is also updated in the guidelines for certain subset of patients. I really don't think that you need to waste your time looking into these details. I think this should be for infectious disease board. هذه from the up to date. يمكن if you want best to look into this table, best to be familiar with the names in case it appears in your exam. Okay, an HIV positive man presents to the walk-in clinic, CD4 count of 120, but has declined to start antiretroviral medication so far. He has not been compliant with prophylactic Bactrim because of nausea. He complains of progressive headache and double vision. An examination, temperature 37.5, has right-sided 6-nerve cranial nerve palsy. The rest of the physical examination is normal. Brain imaging is shown. And please have a few minutes to look into the brain imaging. What treatment should you start? So anti-TB, Septaz and vancomycin, amphotericin, sulfadiazine and pyrimethamine, brain biopsy. So let's and just take a few minutes here. I think if it is TB, they will give you more clues in the question. Some B symptoms, some exposure history, chest X-ray finding, and they will give you something in the question that will make you think, maybe this is TB. Abscess, and for the treatment of ceftazidime and vancomycin, well, yes, like usually one biogenic abscess is usually solitary, especially if it is in the brain. Usually حتى لو كان more than one lesion, biogenic brain abscess, usually بتكون on one side, ما بتكون two sides, unless it is related to infective endocarditis and embolization from the heart. IV amphotericin B and flucytosine. This is not the classical radiological finding of cryptococcal meningitis, and this is not the classical description of a cryptococcal meningitis. These are masses with midline shift. We usually treat empirically for toxoplasmosis, and then we repeat imaging in 2 weeks, and if there is no response, at that time we do biopsy. So, because I think this is the other very important clinical syndrome in terms of opportunistic infection in the setting of HIV that is probably important for the internal medicine board. The first one can be pneumonia, and I think the 3 most important diagnoses are pneumococcal pneumonia, TB, and PJP. And this is for the brain. So if they give you an HIV patient with a brain imaging, either نفس imaging or a description of the imaging, pay attention to the description or look into the imaging carefully. طبعا always put down what is the CD4 count. So if it is less than 200, then we are talking most likely about opportunistic infection. If there is a mass if there is a lesion with a mass effect, then we are talking most likely about toxoplasmosis, lymphoma, or others. And here I put them all together because they are less likely to be presented in the internal medicine board. I know cryptococcosis here is one of the differential diagnoses, but this is not the classical radiological images. Plus, in the internal medicine board, I think more likely in the toxo will appear than cryptococcomas. So the distinction would be between toxoplasmosis and lymphoma. Toxo is usually multiple brain lesions. Lymphoma is usually a solitary lesion. Toxoplasmosis is usually toxoplasma IgG, not usually. It should be positive. Then it is usually a reactivation of the disease. And if the toxoplasma IgG negative, then this patient should go immediately to brain biopsy and not wait for the first 2 weeks. If there is no mass effect, then we are talking about probably other viral infection like PML, JC virus, or CMV as differential diagnosis, but also others like AIDS-related dementia could be one of the differential diagnoses. Sorry, the previous slide. Harry, for the treatment of toxoplasma, I really think حتى treatment of toxoplasmosis probably is a bit too much for internal medicine board, and by the time it is toxo, I would say everybody will refer to infectious disease. Like in case they ask you, these are the first choices, and these are the alternative in case of any, let's say, intolerance or allergy or whatever. HIV patient with CD4 count of 110, not taking any medication, present to the urgent care center with complaints of headache. Also notes nausea and intermittent blurred vision. Examination is notable for normal vital signs with no fever, but there is mild papilledema. CT scan did not show any dilated ventricle. The definitive, or actually did show, does not show dilated ventricles. The definitive diagnosis of this patient is CSF, MRI with gadolinium, ophthalmologic examination, serum cryptoantigen, or urine culture. You can quote. So this is an HIV patient with low CD4 count, who's presenting with headache and other CNS manifestation. Most likely, the question is probably asking about a subacute infection in the setting of HIV, and it tells you that the CNS imaging did not really show anything significant. We need to do lumbar puncture, and we really need to look into the CSF culture for the diagnosis of potential meningoencephalitis, like most likely what we are looking for is cryptococcal meningitis. 32-year-old male patient presents to the emergency department with increasing confusion over the past 4 weeks, non-compliant to antiretroviral, not attended the clinic for the last 6 months, denies any headache and neurological symptom, but score 0 on 10 on mental test score. Neurological examination reveals a 37 temperature, left-sided, pass pointing, and dysdiadochognesia. CT of the head showed no focal lesion. CSF showed a protein of 0.8, glucose normal, serum cryptococcal antigen or CSF cryptococcal antigen is negative. White blood cell and RBCs are also quite low from the CSF. And the question is asking which treatment is most likely to improve this patient's symptom. So this is most likely an HIV-related dementia, or what we call hand syndrome, and the most, or it could be the other differential diagnosis could be JC virus, and in both conditions, starting patients on antiretroviral medication is the best treatment. Okay, sorry. 36-year-old a male patient with HIV successfully treated for PJP pneumonia, readmitted 10 days later with acute shortness of breath and left-sided chest pain. Examination reveals hypoxia and reduced breath sounds on the left side of the chest. What is the most likely diagnosis? Relapse, pericarditis, pulmonary embolism, pneumothorax, or acute coronary syndrome? Okay, excellent. So this patient is definitely at risk for pneumothorax infection, pneumothorax complication. طيب. A 29-year-old man presents with painful white patches on the mouth. On physical examination, there are irregular white patches on the edges of the tongue, which cannot be dislodged when probed by the swab. On direct questioning, he admits frequent unprotected encounters with commercial sex worker. HIV test is positive. What is the best treatment for these patches? And these are the choices. Please feel free to vote. Okay. So this is white patches that cannot be dislodged. Usually Candida usually can be dislodged with the tongue depressor. This is a geographical tongue seen in patients with HIV and usually resolves with antiretroviral medication. 32-year-old male patient present with scaly patches on the forehead with excessive hair dandruff. He has a hyperpigmented scars on his upper torso consistent with healed zoster lesion. What is the most important investigation? Um, So because of the constellation of symptoms with the skin manifestation, this is really worrisome for tuberculosis and I think, sorry, for HIV and the right correct answer is HIV. And these are the AIDS defining criteria that maybe you may get questioned or tested for. And I think one of the most important thing is recurrent HSV or VZV infection, cryptococcosis, extrapulmonary tuberculosis, lymphoma are all will all يعني can be a presentation of acute HIV, and these are the cutaneous manifestations that could present as an acute HIV. Okay, let's take this question. 49-year-old with HIV with a combination of combination therapy with tenofovir, emtricitabine, and combination lefonavir, ritonavir. CD4 count is 50, viral load is undetectable. He received 1 week course of Cipro 2 weeks ago for UTI. His 9-year-old daughter is unwell and for 1 month ago with fever and facial rash. He's complaining of severe lethargy and easy fatigue. His blood results showed a hemoglobin of 56 and an LDH of 240. What is the most appropriate treatment? Okay, So this is most likely a parvovirus infection, given the recent contact, and the treatment is IV immunoglobulin. 25-year-old woman known to have HIV positive or found to have HIV positive during the antenatal screening at 24 weeks. CD4 is 550, HIV viral load is 20,000, takes no medication. Which of the following is the most appropriate management for this patient? Initiate antiretroviral with the CD4 count falls below 500. Initiate antiretroviral as soon as possible. Start antiretroviral therapy at 28 weeks of gestation, and then plan elective cesarean section. Initiate antiretroviral at 2 weeks before the expected date of delivery or terminate pregnancy. You can vote. Please, this question should be 100%. أصلا دحين for all HIV positive people HIV antiretroviral medication is indicated at any time. يعني ما عاد في CD4 count below ولا antiretroviral ولا HIV RNA more than this cut limit. We treat all HIV positive patients, and these are the new recommendation, not the new. This has been the recommendation. Especially for HIV pregnant ladies, you have to initiate antiretroviral as soon as possible. لأنه in pregnancy, remember إنه في two ways of fetal transmission: vertical through the placenta, يعني during the pregnancy, and this is how we prevent it by giving the mother antiretroviral medication and making sure that her viral load is undetectable. And the other one is during delivery for patients who are not previously controlled or not previously diagnosed. And here we usually give the fetus, if we know the mother is HIV infected, we give the fetus the prophylactic or the prophylactic treatment to prevent the transmission. Regarding occupational HIV transmission, which of the following statements is correct? HIV average transmission rate through needle stick is 3%. Large bore needle injuries do not increase the risk of HIV transmission. Higher HIV viral load increases the risk of transmission after needle stick to 5%. Post-exposure prophylaxis is not indicated unless the source is known to have HIV. Any antiretroviral medication can be used for the prophylaxis. And you can vote now. هذا الإجابة هذه اللي هنا محطوطة خطأ. This is not the correct answer. The correct answer is this one, C. A higher viral load increase the risk to 5%. This is not the correct answer. 3% is actually a high percent. I wouldn't I don't think it's acceptable 3%. Like in HIV transmission in average is not 3%. And like with the higher the viral load, the more the chances that infection will happen. So it's around 5% with high viral load. And this is a slide about occupational HIV exposure. So for post-exposure prophylaxis, HIV screening of the exposed individual should be performed at baseline. If fourth generation antibody test is used, follow-up testing performed at 6 weeks and 4 months after the exposure. If the test only measures the antibody, then repeat it at 6 weeks, 3 months, and then 6 months. Post-exposure prophylaxis, we have to give a 3-drug regimen. These are the indications so far. This is expected to change in the near future because of tenofovir and switching it to the more safe tenofovir formulation that is currently available. When should you consult an ID physician for post-exposure prophylaxis? If there is a delayed exposure report, so let's say, an employee was had a needle stick injury, and then 3 days later he knew that the source is HIV infected, and now they will call you to deal with that. Then you would expect HIV or infectious disease physicians to be involved. Unknown source, pregnancy or lactation in the exposed, known or suspected resistance in the source, toxicity of the first post-exposure prophylaxis, or serious and medical illness for exposed person. 27-year-old man presents to your clinic with 2 weeks history of sore throat, malaise, myalgia, night sweats, fever, and chills. He visited an urgent care center and was told that he likely had the flu. He was told that he had negative test for mono. The patient is homosexual and states that he is in a monogamous relationship. He had several partners before his current partner 4 years ago, but none recently. He reports negative HIV-1 test 2 years ago and recalls being diagnosed with chlamydia infection 4 years ago. He's otherwise healthy with no medical problem. He wished to rule out the diagnosis of acute HIV. Which blood test would you order? خلاص آخر كلام؟ لا. I think the word acute في الexam or في question is really meant to direct your thinking toward HIV RNA. لأنه sometimes the combination test or the antibody test takes longer time to become positive. So for the boards for HIV, you really need to remember the exposure and post-exposure prophylaxis. When should you give within the first 3 days? There is a certain agents that is used for post-exposure prophylaxis. The only reason we switch from this combination is if we know that the source is HIV positive and has a resistance of some sort. The AIDS defining condition are very important. The CD4 count and the risk of infection and the infectious agent. CNS disease, toxolymphoplasma, lymphoma, crypto, and TB. Crypto and tuberculosis usually presents with meningitis and or brain lesions. Like, you have to have a clue in the question. I would think CMV will be a less likely infection. Pulmonary disease, as I mentioned previously, and the ART and their side effects. And as I mentioned, I think the table is inclusive. Okay, 27-year-old lady presents with a swollen, hot, and tender right knee. On examination, there is a pustule in the web space on her hand. A culture from the following sites is likely to reveal the causative agent. Knee aspirate, blood, upper vagina and cervix, pustule fluid, or culture requires special media. So, this is a 27-year-old female. Why do you think she will present with septic arthritis? No medical illnesses, only 27, but then this pustule and the web between the fingers, and this is a classical description of disseminated gonococcal disease or DGD. So, and that's usually require upper vagina or cervix swab for the diagnosis in females. We'll talk about the DGD later in the later slides. 23-year-old man presents with pain in multiple joint 1 week after returning from a vacation in Europe. He describes fleeting arthralgias beginning in both knee, migrating to both wrists intermittently. His main complaint is of severe pain in the left knee. On examination, his febrile 38.5, the knee is swollen, warm, and tender. Several postural lesions are noted in the 3 digits of his right hand. White blood cell showed 12.3 ANA and rheumatoid factor are negative. Blood culture is negative after 48 hours. Knee aspiration showed turbid fluid with numerous polymorphs. Which of the following is likely to be seen on the microscopic examination of synovial fluid? You can vote. Okay. Extant are expected to see gram-negative diplococcal. So gonococcal infection. So now in men, the most common manifestation is urethritis epididymitis. The diagnosis for this clinical manifestation is urine for NAT, urethral swabs, or with urethral swab sent for gram stain culture and NAT. For females, it will be cervicitis, vaginitis, and the required samples for the diagnosis is vaginal swab or endocervical swabs. Both of them can present with anorectal gonococcal disease, pharyngeal gonococcal disease, ocular or disseminated gonococcal infection. And the diagnosis is usually made by identification of the Neisseria gonorrhea in the blood, synovial fluid, or skin. And usually, if it is, you will see the poly or oligoarthritis. This is more likely the one that will give you the diagnosis from the synovial fluid. If it's a one joint, then this is most likely going to be probably just a reactive arthropathy, and you may not find any positive culture from the synovial fluid. For DGI or diffuse gonococcal infection, bacteremia is also another thing that you may find. So if you expect this patient to have disseminated gonococcal disease, then you will send for a blood culture. طبعا painful joint and tenosynovitis with skin lesion, we call it arthritis dermatitis syndrome. Polyarthralgia usually involves the knees, elbows, or distal joints. Skin lesion present in the 75% of the patients, which include papules and pustule with hemorrhagic component. And this is where you will see the distinction between reactive arthritis and disseminated gonococcal disease. So, for example, if it is an elbow, then most likely this is a disseminated gonococcal disease more than reactive arthritis. On the other hand, if you have a spine or sacroiliac joint, then it is most likely to be, more likely to be a reactive arthritis rather than being involved directly by the organism. And as you can see, the knee has both equal distribution in both, so you really need to pay attention to the information that is given in the question. A 34-year-old single man presents to the emergency department with severe pain on defecation with bloody mucus and low-grade fever and malaise. He travels regularly to Southeast Asia and Europe for leisure. Proctoscopy was not possible because of pain. The remainder of the physical examination was normal. No skin, genital, or oral lesion. He receives a single dose of IM ceftriaxone and is given a course of oral acyclovir. The patient returns 1 week later and reports that his symptoms have not improved. Rectal swab were negative for HSV and gonorrhea. What pathogen should you suspect? خلاص آخر جواب أكيد perfect. Chlamydia. So when to suspect chlamydia في الexam? Any clinical syndrome that looks like gonorrhea لكن it is not gonorrhea، يعني زي هذا السؤال بيقول لكم إنه patient received treatment for gonorrhea لكن did not improve، then think of chlamydia. So non-gonococcal urethritis, 2 to 3 weeks after the treatment for gonococcal urethritis, patients with urethritis with white blood cell urethral oxidate but negative for gonorrhea. Now طبعا we have the GC NAT which detect both organisms, so it made it easier. Epididymitis cervicitis can also present with reactive arthritis. One of the interesting يعني more recently we knew more about it is the proctitis, and this is more seen or more commonly seen in MSM لكن there are also reports in women. Usually presents with severe anorectal pain, bloody mucopurulent discharge, and tenesmus, and this could potentially make you think more of chlamydia than gonorrhea. LGV is a small painless papule that tends to ulcerate at the time of the inoculation and then can cause painful inguinal lymphadenopathy within weeks from the exposure, and usually it's a unilateral disease. So this is the diagnostic test for chlamydia. Again, you will be able to look into this slide later, but here the table summarized the different clinical syndromes and then the suggestive signs and symptoms, and then the test or diagnostic test of choice that you should send. So male with urogenital infection NAT in the urine, female with urogenital infection NAT in the urine, cervix, or vaginal swabs, extra urogenital infection rectal for NAT, and if it is in the lymph node or LGV, then you will send some of the material for NAT. 41-year-old single man presents with 2 large fleshy, flat, painless, moist, purely gray lesions on either sides of his anus. What is the most likely diagnosis? Don't forget, the question did not ask you about painful or painless ulcer. يعني هذه ما هي genital ulcer. This is lesions around the anus, away from the genital areas. So this is condyloma acuminata. Okay, 22-year-old male, HIV and antiretroviral, presents with several large 1 centimeter painful penile ulcer along with a fluctuant left-sided inguinal lymphadenopathy. He notes that it started around 1 week ago as pimples. He was given acyclovir for several days with no improvement. Gram stain of the drainage fluid shows gram-negative rods. What is the best treatment option? So قال لكم جرام نيجاتيف صح؟ So في كثير حيروحوا valacyclovir out, doxycycline most likely this is not يعني brucellosis, this is something in the urogenital tract. ممكن doxycycline بس هحطه شوية تحت لحد ما أشوف الكلينيكال syndrome. Azithromycin, maybe I'll put it again down and I look into the clinical syndrome. So the clinical syndrome is describing painful and painful ulcers plus lymph nodes that are purulent lymph nodes. So here we are talking about a different clinical syndrome, and I'm going to have a table that summarizes the different ulcers in the urogenital tract and how to differentiate between them in the exam. 28-year-old man presents with 1 week history of painless ulcer on the tip of his penis. He returned from a holiday around 1 month ago. Which of the following diagnoses is unlikely? Syphilis, HSV, granuloma inguinale, Reiter's disease, chancroid. خلاص متأكدين؟ مين من ال following diagnoses is unlikely؟ طيب جماعة اللي اختاروا primary syphilis بصراحة the classical description of a primary syphilis is painless ulcer, and sometimes the patient حتى they don't notice it. بينما the classical presentation of genital herpes infection is very painful ulcer, and here the question is asking you what is of these infections is unlikely to be HSV, who are painless. Okay, so this is the table that I was telling you about. So here I divided the infections by the clinical syndromes. So HSV, chancroid, syphilis, LGV, and granuloma inguinale. You will have the etiological agent, and then مين فيهم اللي painful. So HSV and chancroid are both painful. Usually an ulcer في chancroid can resolve يعني quickly, and then they will have the lymphadenopathy. And usually lymphadenopathy is what makes them present because it's usually unilateral suppurative, and this is caused by Haemophilus by Haemophilus infection, and the treatment for this one is mainly ceftriaxone with multiple ulcers. And then you will have the 3 other diagnoses that has a painless ulcers for presentation, and then you will have different clinical characteristics that make you differentiate between them. So for example, syphilis is usually primary syphilis is actually unnoticed. The patients will not even notice it. Like if they do, it's usually a single ulcer, clean base, heals spontaneously. In comparison with, for example, the other 2 diagnoses, which you can see, المشكلة ما هي في الألسر itself, لكن في lymphadenopathy reaction that happens around the ulcer, with, for example, with LGV, that it really becomes large with fluctuance, and there is discharge. So really is a significant disease, and their presentation significantly بتكون هي lymphadenopathy أكثر من الألسرز. Okay. 56-year-old woman presents with recurrent episode of dysuria with localized tingling of the genitalia and shooting pains. Which one of the following is true regarding genital herpes? Recurrent episodes tend to be more severe. Transmission cannot occur in the absence of lesions. Most primary cases present with symptoms. Topical acyclovir is the treatment of choice. خلاص متأكدين؟ لا في ناس قررت إنها مو متأكدين. So the initial answer was correct. 41-year-old male patient present with seasonal allergies, GERD, hyperlipidemia, presents to the clinic with 2 months history of fatigue, generalized body ache, several weeks history of rash that is described as faint paint macule, pink macules on the trunk and arms with scaly erythematous macules on the hand. He reports subjective fever but denies chills and night sweating. Which one of the following tests will likely yield the diagnosis? Syphilis serology, measles, dengue, blood culture, or blood smear for malaria? And what? ما شاء الله. يا دوبني فرحت. Syphilis antibody. So this is a classical description if you look into the case. This is several weeks or 2 months, couple of months history of generalized body ache, rash, The rash is classical description. But there is no other systemic symptoms. Measles does not stay for 2 months. Dengue does not stay for 2 months. Blood culture to be positive. What is the clinical syndrome? And infective endocarditis. They will give you more things in the question. Malaria does not stay for 2 months. 64-year-old man presents with 2 weeks history of confusion. Sorry, 2 months history of confusion, no previous history of cardiovascular peripheral vascular disease. For example, he's febrile. Neurological examination demonstrate attacks at gait and reduced coordination, but no meningism. Which of the following tests is the most appropriate to establish the diagnosis of tertiary syphilis? You can vote now. MRI of the brain, يعني what do you expect to see? Bleeding عشان myocardial aneurysm البرزنتيشن ما حتكون كده. tertiary syphilis معناته إنه he had an infection and a serology that will never turn back negative. So let's look into the syphilis testing. عندنا generally troponemal and non-troponemal, and I'm aware that time has passed, so please let me know when do you want me to stop. So troponemal and non-troponemal testing. The non-troponemal testing here listed here, and I want you to remember RPR and BDRL. And then the troponemal testing, a lot of tests لكن عندنا في المملكة FTA عندنا agglutination assay وعندنا ال MHA لكن يعني these tests, some of them are available in the kingdom. If it's positive, then it stays positive for life, regardless of treatment or no treatment for the patient. So what do we currently do, or what is the recommendation now, is to go with troponemal test. زمان كانت we do non-troponemal, and if it's positive we do troponemal. Now, no, called reverse syphilis algorithm screening test. So we start with a troponemal test, and then if it is positive, then we go for the non-troponemal test. لأنه المين thing اللي احنا نبغى نشوفه whether it's reactive or non-reactive. Why? And we know, with troponemal test, it will be positive for life. So if it is positive, this patient may have been treated in the past. So if the RPR is non-reactive, then you want to make sure, especially if the clinical syndrome fits the diagnosis of tertiary syphilis, then you will do another troponemal test. And if both of them are positive with a negative RPR, then probably there is an exposure to syphilis. Like, this is a very complicated and really usually depends on the clinical syndrome. So I don't want you really to bother about that. What I really need you to focus on for the exam, if the troponemal test is positive and then you do an RPR, if it is reactive, then it is consistent with syphilis, whether it's past or current. What will make you know whether it's past or current? The titer. If the titer high, and high في syphilis يعني 1 to 4 ولا 1 to 2 is high. ما المفروض تكون 1 to 2 يعني 1 to 4. This will tell you that there is still an active syphilis infection. Whether it's tertiary or whether the patient is now presenting with tertiary syphilis and the complication of tertiary syphilis, especially if we're talking about CNS manifestation. And I think this is what will, if it's going to appear in the exam, this is what will appear in the exam. 31-year-old man present with headache and low-grade fever for 3 weeks, has a maculopapular rash noted over his entire body, including palms and soles, in addition to painless oral ulcers. Neurological examination and CNS were remarkable. Serology showed an RPR 1 to 320 and FTA antibody positive. CSF reveals a white blood cell of 100% lymphocyte with is normal protein and glucose. CSF VADRL is non-reactive. Which course of management is the most appropriate? So these are the treatments. شايفة. So في ناس تبغى تعطي بنزاتين penicillin IM weekly for 3 weeks. And few people, and I'm looking at the majority of people, they want to give him IV for 14 days. Few people are okay with doxycycline. Doxycycline is the correct answer. Let's look why. So this is a patient who is likely to have a secondary syphilis, صح? In endo skin lesions. And with this skin lesion, there is a finding suggestive of CNS involvement. Now, with secondary syphilis, there could be an abnormality in the CSF that does not necessarily mean this is a CNS syphilis. So it does not require a treatment for CNS syphilis. And the clue here, in CSF VDRL is negative. So this is just a reactive CSF pleocytosis from the severity of the secondary syphilis, and the treatment should be directed toward management of secondary syphilis. I think I will take this. Which one of the following patients with latent syphilis should undergo lumbar puncture? 24-year-old woman with RPR 1 to 128, 38 with an RPR of 1 to 332 with benzathine penicillin intramuscularly, and the repeat titer is still 1 to 16. 46 with HIV and a CD4 count of 150. 62 with Bell's palsy and recent change in the mental status. ولا all of them? What do you think? All of the above. The 24-year-old woman has a very high titer. The lady who was treated and she still has a significant titer you'll need to rule out CNS involvement. HIV patient, you will always need to do, if their syphilis serology is positive, you will need to do CSF. لأنه a relation between HIV and syphilis does not respect stages. So CNS syphilis can present at any time in HIV patients, and a patient who is presenting with some neurological manifestation. This is the indication to do CSF analysis in sepsis, so in HIV less than 350. لكن any patient who is presenting with حتى لو كان يعني primary or secondary syphilis, most of the ID physician will still do CSF analysis, and as I mentioned later or earlier, they could present with syphilis at any time. All patients, signs and symptoms of CNS involvement, ophthalmologic involvement, RPR titer more than 32, active tertiary syphilis, ولا suspected treatment failure. 32-year-old woman seen with 3 weeks history of vaginal discharge with unpleasant smell, washing frequently, including regular use of Dettol, married for the past 5 years and never had any other sexual partners. The examination showed thin white discharge with fishy smell. What is your diagnosis? And it should be very quick. Excellent. And the description is very classical for bacterial vaginosis. 58-year-old gentleman presents with shortness of breath with worsening over the past 6 months in association with retrosternal chest pain. He sleeps on 4 pillows and denies any paroxysmal nocturnal dyspnea. He can't remember if he has had any rheumatic fever as a child. He moved from South Africa to Saudi Arabia 15 years ago. Recently, he had been complaining of low back pain and diagnosed with arthritis by the general physician. No skin lesion. As a young man, he received a course of penicillin for sexually acquired infection. His medical history includes systemic hypertension, arthritis. Current medication include amlodipine and ibuprofen. The chest X-ray shows cardiomegaly, calcification of the ascending aorta and aortic arch, and a possible aortic aneurysm, which is the most likely diagnosis. خلاص آخر كلام. Perfect. So here in this table, and you will look into this طبعا when you have time. This table summarizes the treatment for syphilis according to the stage, with the alternative treatment for patients who are penicillin allergic. 26-year-old with itchy malodorous vaginal discharge. Her vulva is erythematous. There is a vaginal inflammation and punctate hemorrhages on the cervix. Microscopy of the genital specimen demonstrates motile flagellated protozoan. What is the most appropriate initial treatment? You can vote. خلاص متأكدين يعني. Perfect. Metronidazole. 24-year-old female in a monogamous relationship had a vaginal discharge diagnosed with trichomoniasis based on the microscopic examination. She received 1 dose of metronidazole, which is the previous question, and the discharge improved. 3 weeks later, she had a recurrence, and she was retreated with 1 dose of oral vancomycin, again improved. However, the OBGYN is calling you because she is in the office with a 3rd episode of recurrence. And again, it is Trichomonas vaginalis. So what will be your answer to the OBGYN? Look at the options and start voting. خلاص آخر كلام. Perfect. You will always have to treat the partner in Trichomonas vaginalis. Okay. So STI for the boards. So what I think you need to know for the boards for the sexually transmitted disease, gonorrhea and chlamydia, and I think the tables I provided you will probably be enough. The different differential diagnosis of genital ulcers with their presentation and treatment, treatment for syphilis, syphilis serology interpretation, stages of syphilis, are also very important for the boards. And then طبعا the other sexually transmitted diseases, which one that you need to treat the partner, which one that does not need treatment of the partner, and what is the first option for the treatment. So for example, bacterial vaginosis, you don't need to treat the partner. Trichomoniasis, you really need to treat the partner, and these are the options for the treatment. Okay. So ساعة 9 يعني I'm aware إنه I'm 30 minutes beyond the time. A number of questions left. I think إنه you're probably تفضلي عفوا ما سمعت.
If you don't mind and your time allows, can we continue, please?
Sure. Let's agree and احنا will do 30 minutes more, and if there are more questions left, then you will have the handout, and feel free to يعني, email me if you have any question.
Sure, thank you.
24-year-old, sure, my pleasure. 24-year-old man is readmitted with fever and chills, night sweats over the past 3 days. He underwent extensive small bowel resection for inflammatory bowel disease 3 weeks ago, and had been seen since been on TPN. On examination, his temperature is 38.9, blood pressure is fine, his pulse is 88 pick, line in the right arm with no erythema, tenderness or fluctuation over the catheter. Has a leukocytosis, chest X-ray is fine, urinalysis are remarkable, and the blood culture is growing yeast within the first 24 hours. Which of the following is the next best appropriate or the next appropriate step in the management for this patient? So these are the choices. Please look at them carefully and answer. Okay. So candidemia this most likely can be TPN, line, candidemia, line has to be out, has to be removed. No change over guide wire, no let's keep it and treat and see what will happen. This is for the exam. Do we do other things أحيانا في real life? Yes, depends على يعني condition of the patient. For the exam, لأن exams are based على facts, which is the guidelines. The guideline says line should be out. This is the one thing, first thing. The second thing, any patient with candidemia, we don't give them initial treatment, we don't give fluconazole because of the risk إنه ممكن تكون the other fluconazole resistant candida. So echinocandin are usually the best treatment for those patients. So in the IDSA guideline, remove the line, start echinocandin. Fluconazole can be accepted if not an ICU or no risk factor for azole resistance, which is probably is going to be too complicated for an exam question. لكن لو قالوا لكم يعني they mentioned في الexam قالوا no previous ICU admission, no previous azole exposure, يعني they give you more details to say this patient can be treated with azole, that's fine. But most of the time, especially in the internal medicine board, empirical treatment will be echinocandin. 36-year-old woman with history of diabetes, hypertension, end-stage kidney disease, presents to the emergency department with double vision. She's on chronic hemodialysis, missed her last appointment. She notes 12-hour facial swelling and difficulty speaking. She is febrile and her facial examination is shown in the next slide. The laboratory investigation showed a white blood cell 15,000, high glucose, high serum creatinine, A1C at 9.7. She is acidotic, and the needle biopsy of the retroorbital mass revealed a wide, thick-walled, ribbon-shaped, non-septate hyphal organism. And this is the patient picture. So what will be, or which of the following is not part in the initial therapy? Not part of the initial therapy. Because it's a very interesting distribution, so I'm going to spend some time here. So this is, just look into the question. Okay. This is diabetic, 1. End-stage kidney disease, 2. Very rapidly progressing infection, over 1 day and had double vision, 3. Chronic hemodialysis, missed her dialysis, 4. She's clearly infected because of the inflammatory markers and the temperature. Hemoglobin A1C 9.7, serum glucose 2.5, so uncontrolled diabetes, acidosis. And the biopsy showed wide, thick-walled, ribbon-shaped, non-septate hyphal organism. So I think the diagnosis is given. So diagnosis is clearly mucormycosis. And any internist or حتى non-internist, surgeon, neurosurgeon, transplant surgeon, ENT surgeon, ophthalmologist, everybody should be aware how to diagnose mucormycosis. So this is clear mucormycosis. So if you have a patient with mucormycosis, and I'm sure إنه أنا دحين لو عندكم patient في emergency room, I'm sure إنكم كلكم حتجاوبوا الإجابة الصحيحة. You will do the right things. This is a patient. You will immediately call the surgeon, start the patient on liposomal amphotericin B, and control her glucose. صح؟ كلنا حنسوي كده. This is not the time when I'm going to send this patient for hemodialysis. لأنه now hemodialysis is not a life-saving procedure. لكن the other 3 is we really need to control the blood sugar. We need to get her into the OR as soon as possible, and we really need to start her antifungal as fast as possible. So hemodialysis is the correct answer, and no, this is not an emergency now in this patient. Hemodialysis is not something that I should do now. But which of the following is the most common form of infection in patients with mucormycosis? Cutaneous, GI, hematogenous, pulmonary, ولا rhinoseptal? أنا أتمنى إني أقدر أسأل those who said pulmonary, how many cases of pulmonary mucormycosis not you've seen, heard of in your hospital. أنا أشتغل in a transplant center, I saw only one case. So pulmonary is not the commonest manifestation. Rhinocerebral is by far the most common clinical syndrome of mucormycosis. 45-year-old lady receiving chemotherapy for acute myeloid leukemia, neutrophil count is less than 0.5 for the past 2 weeks, so there is a prolonged neutropenia. She has persistent fever more than 38 despite being on IV cefepime for the past 5 days, and the CT showed bilateral pulmonary nodule surrounded by ground glass opacity. ما أعرف رجعت كذا. You started voting. Okay, excellent. So what is your diagnosis, or what is the most likely diagnosis? Think again, huh? So hospital-acquired pneumonia, why would I tell you إنها leukemia وكيمو 2 weeks neutropenia وسيفيبيم not responsive؟ يعني it would be probably different clinical scenario. Herpes simplex pneumonitis, again, يعني I don't think I should go through all the hassles of putting the most recognized risk factor for invasive pulmonary aspergillosis عشان to diagnose or to test you on HSV pneumonitis. Pulmonary candidiasis is for ID physicians does not exist. يعني ما في شيء اسمه احنا ال ID we don't think there is candida pneumonia unless you give me a biopsy that shows an extensive infiltrate of the lung by candida. Otherwise, we don't really think of candida pneumonia as an entity. So this patient is the classical patient for the development of acute or invasive pulmonary aspergillosis. AML, prolonged neutropenia, fever for 5 days without any improvement on antibiotic, anti-pseudomonal drug, with a CT scan that shows nodules with ground glass opacity, which is suggestive of Halosign. 20-year-old man is receiving aggressive chemotherapy for AML, peripheral white blood cells 0.1, persistent fever, significant shortness of breath, cough, pain. There is no significant shortness of breath, cough, pain, or GI upset. The Hickman line site appears clean with no signs of inflammation. Chest X-ray showed bilateral infiltrate with possible pulmonary nodule. Blood culture were taken from the peripheral blood, and he was started on piperacillin tazobactam and amikacin. Which of the following is the next important step in the patient management? Okay, so probably all these answers are correct. So probably in a given day, for the same patient, we'll do all these at the same time. We'll tell the team to arrange for a CT and do bronch and do blood culture and add vancomycin and probably add caspofungin and so on. But the important thing is that this is a patient who is definitely at high risk for, again, invasive fungal infection, not necessarily invasive aspergillosis. So not only has a profound neutropenia and fever, but the chest X-ray, which is usually misleading في الهيماتولوجي patient، لأنه أحيانا chest X-ray تكون negative في الهيماتولوجي patient، تكون negative ما فيها شيء. لكن هنا chest X-ray did actually show pulmonary infiltrate, probably pulmonary nodule. So the first important thing at this stage that we really need to characterize these pulmonary nodules. This patient should go now to CT scan. And what will happen next, should we send this patient for bronchoscopy and BAL if his platelet allows? Should we send this patient back to biopsy if the platelet allows? Are we going to start empirically antifungal management without waiting for BAL because the chest X-ray or the CT scan is full of finding that is suggestive of invasive fungal infection, and the patient could potentially die because of invasive fungal infection? So it's just here the question is arranging or asking you, how will you arrange your priorities for investigating this particular patient? 31-year-old male patient presents to the emergency department because of high-grade fever and multiple painful skin nodules over the past 2 days. The skin lesions are red, painful, gradually developed on both arms before spreading to the chest and legs. He noticed fatigue, poor appetite, dry cough, and mild shortness of breath. 1 week ago, he was helping his father in the farm. The patient had an allogeneic bone marrow transplantation for acute leukemia 3 months ago, complicated by pneumonia, catheter-related bacteremia, GVHD, and he's on steroid. He's also on valganciclovir and Bactrim. He's febrile, bit hypotensive, tachycardic. Exam showed dry mucous membrane, diffuse crackles in the lung field with splenomegaly, and the skin examination revealed dry skin with multiple raised erythematous tender nodule on both upper extremities, lower extremities, and upper chest. The laboratory investigation showed hemoglobin of 8, white blood cell of 18,000, neutrophil 98%. Patient is admitted to hospital and started empirical treatment, and the blood culture grew mold-like organism. Which of the following is the most likely cause for this patient condition? You can vote. Okay, I will look here, Leno. I think we need to do some. So is nocardia mold or bacteria? Bacteria. So it should go out. Is candida mold or yeast? Yeast. So it's out. Histoplasma, 2 things will make me exclude them. أولاً, it is a yeast, not a mold. ثانياً, please forget histoplasmosis. You are not an endemic country for histo. If the exam ما جاب لكم سيرة travel to the United States, Mississippi ولا Ohio Valley ولا يعني around the Mississippi rivers, please don't choose histoplasmosis. يعني I'm not really sure why everybody من الميديكال trainees are obsessed with histo. يعني I'm sure إنكم بحياتكم ما شفتوها. فhisto is out. Histo should be في الإكزام something related to travel. HIV كان برا وجانا with diffuse lymphadenopathy, blood culture is growing yeast. It's not a mold. Aspergillus does not grow in the blood culture. It does, بس يعني it is not recognized as a fungus that usually grows in the blood. Extremely rarely, and most of the cases reported in the literature, gallinate is a contaminant. So the diagnosis is Fusarium. The clues in this question, and for an internist, what I really need you to remember, أولاً لازم يكون bone marrow transplantation. طبعاً it doesn't mean it only happens in bone marrow transplantation. It does happen in other immunocompromised, but for an internist, this is what I want you to remember: bone marrow transplantation. Second thing, the fungal infection that give you multiple tender skin lesions at the extremities with a blood culture that is growing mold, don't even waste your time in looking into what are the available options في السؤال. دوروا على الفيوزاريا. This is a classical description of fusarium. Okay? And please, next time when you answer the question, شوفوا الديتيلز اللي أعطاكم إياها في السؤال. هنا they mentioned إنه it is mold. they mentioned, it is this is an allogeneic bone marrow transplant patient. They mentioned the details of the skin lesions. So it's very, very important that you look into those details and try and exclude the things حتى لو ما تعرفوا إنها fusarium, exclude. So histo, nocardia, and candida will go out. And then by the common sense, do we hear or see people with aspergillus infecting the skin? Yes. لكن to grow a blood culture, ما أعتقد إني عمري شفت. Probably it's fusarium. Okay. So fungal infections for the board, candidemia, always remove the line and start echinocandidae. زي ما قلت لكم أمس, البورد does not test you في الكلينيكال سيناريوز اللي احنا during the rounds we debate. شو نشيل اللاين ولا ما نشيل اللاين, نبدأ ولا ما نبدأ. البورد will ask you about facts. We're driven mostly from guidelines. So guideline says candidemia, remove the line and start echinocandin until this culture identification susceptibility is out. De-escalation can happen after the final cultures. Important differential diagnosis of yeast in the blood in immunocompromised patient is cryptococcosis. So لو جابوكم especially solid organ transplant or HIV patient with a blood culture positive for yeast and you don't think it is candida because of the clinical scenario that they had given you in the exam, and I really think this is an unfair question, then the differential diagnosis is correct. Mucormycosis extremely important. الميوكور حطوها في نفس الكاتيجوري حق الملاريا. ليش؟ Because it's a life-threatening infection. So they will really need you to know the risk factor, the presentation, the treatment, everything about mucor is going to be very important for both written and OSCE exam. So clinical syndromes and treatment. Aspergillus, remember them in the bone marrow transplant and some extent في solid organ transplant. I think for the medicine board الفوكس حيكون البون marrow transplant و most likely حيكون questions زي اللي أنا جبته. Febrile neutropenia patient who's on a broad spectrum antibiotics and not responding. What to do next? CT scan, Aspergillus galactum معنا في serum, bronchoscopy. يعني حتكون around these things most likely. Treatment is the preferred agent is voriconazole. Helosine is suggested لكن is not pathognomonic. لكن في الإكزام لو جبرتم إياه في question probably is a clue for you to choose to choose voriconazole, aspergillus. The others, the most important among the others, probably the medicine board is important because it's very nice to put it in an exam question. هو fusarium. Multiple skin nodule, positive blood culture. Don't think twice, just pick fusarium. Okay. 66-year-old woman hospitalized for the worst headache of her life. CT showed diffuse subarachnoid hemorrhage. Because of the patient deteriorating mental status and agitation, she was intubated and central line was placed. Which of the following is the most effective strategy to decrease this patient's risk for developing catheter-related infection? خمسين في المية اللي اختاروا روتين catheter replacement every 3 days يبغوا يفقروا البلد. It's chlorhexidine. Plus, بالعكس, the repeated procedure increases the patient risk for infection even further. So we don't really prefer replacing the catheter every 5 days or 3 days. So these you will find out this in the handouts. I'm not going to spend time, but this is how you prevent catheter-related infection. And in case you have an infection control question. 23-year-old woman brought to the emergency department with fever, rash, decreased level of consciousness. She's accompanied by her boyfriend. Throughout the morning, she became increasingly confused and eventually unarousable, prompting him to call an ambulance. He does not know any of her specific medical problem, but reports that the patient had an abdominal surgery after a bad automobile accident. After initial investigation lumbar puncture, the CSF showed gram-negative diplococci. The patient is transferred to the intensive care unit. Which of the following is the best initial choice for infectious precaution measures? So in other words, Are you going to put her in isolation, yes or no? And if yes, what will be your order for isolation? Why contact? Neisseria meningitis is not a contact isolation, it's a droplet. It is not an airborne isolation. This is, I think, the most important isolation that may be seen as an exam question for internal medicine board. I think the most important حيكون الايربورن الفاريسيلا especially if immunocompromised. هذه I think حيكون ممكن يكون potential exam question. Tuberculosis طبعا for example. The contact of Clostridium difficile, we washing the hands at the end of each patient encounter. Probably this will be another important question. الدروبلت اللي هي طبعا mostly CNS infection طبعا والإنفلونزا or other respiratory viruses including COVID. 57-year-old lady with chronic congestive cardiac failure present with 2 weeks history, 2-day history of sore throat, fever, rigors, and generalized body ache. Nasal swab is positive for influenza A. Further management should include. I don't think we need to spend time on this question. 14-year-old present with low-grade fever, mucopurulent nasal discharge, anorexia and pharyngitis. A whitish gray membrane is adherent to her tonsils and soft palate. Attempt to remove the membrane is resulted in a bleeding. During the examination in the emergency room, it is revealed that the boy and his family had recently arrived to KSA from Ethiopia, and his vaccination status is unknown. Throat and nasopharyngeal swabs are collected and sent to laboratory for cultures. For optimal infection control, which isolation precaution should you place this patient in while awaiting the results? So you need to make the diagnosis and then think what will be your isolation. Okay. So again, it's droplet isolation. Most of the things that happen في الأوروفارنجيال هيكون if required isolation هيكون droplet isolation. I think we can skip this question. I know it's the same idea. هذه كمان we'll skip it. Then you will have the handout. Okay. 76-year-old woman presents with pain over the left upper chest. She has suffered a weeping vesicular rash over the area for the past few days associated with burning intense pain. She has a well-demarcated rash consisting of dried crusted healing vesicles corresponding with one dermatome. Which of the following options represent the most appropriate management for this patient? Okay, so the diagnosis is shingles, but I'm not going to give her any antiviral لأنه her lesions has already crusted up. Like what she's complaining of now is the post-herpetic pneumonia. All of the following viruses are correctly matched with their primary clinical manifestation except adenovirus with gingivostomatitis, coronavirus with severe acute respiratory syndrome, human respiratory syncytial virus with bronchiolitis in infant and children, and parainfluenza with croup. So what is your correct answer? Okay, excellent. So we don't want to waste time. I think I'll skip this question. I think also this question, I'll skip it. Right. 19-year-old diabetic bitten by a dog while walking to his car in the outer regions of Riyadh. The man had never received rabies vaccination before. The dog is owned by a local family and is reportedly unwell. What is the most important or most appropriate next step? معلش أنا عشان التايم I'll go fast. أصلا ribavirin interferon does not treat rabies. So if you are thinking this patient needs post-exposure prophylaxis, it does not include لا ribavirin ولا interferon. يعني includes vaccine and immunoglobulin. This patient knows the family, or at least we know the family, and we know that they can observe the dog. So if you can observe the pet for 10 days, then this is what we should do. We observe the pet for 10 days, and if the pet, so a dog or any other, died, then we should initiate post-exposure prophylaxis. Like if they still stayed alive, then this is not rabies in the dog or in the other pet, and we should not worry about giving post-exposure prophylaxis for rabies. طبعا الother thing اللي ما فيها waiting, if you cannot really observe the pet or observe the dog, then you will go ahead and give the post-exposure prophylaxis, especially if it is unprovoked. I think I'll skip this question. And this one as well. Okay. 24-year-old woman presents with one-day history of fever and macular rash. She is 8 weeks pregnant and has not been immunized against rubella. Her blood test showed a rubella IgM negative, hemagglutination 1 to 64. What advice would you give this patient? I don't think we can reassure her, and don't forget she's pregnant. IgM is negative probably because still she did not seroconvert. So I'll bring her back to the clinic for repeat rubella, and if it's positive, then we will need to initiate the whole 9-yard investigation for the baby, and to make sure that he does not have or she does not have congenital rubella syndrome. We'll see if the patient fits for immunoglobulin to be given. So with pregnancy and rubella, I don't think anybody will just feel confident to say, fine, you're fine, you don't have rubella, just go home and relax. I think I will skip this one as well. Yes. 17-year-old female, previously healthy, presented 3 days ago to the family medicine clinic because of fever 39.2, responsive to paracetamol. She was diagnosed with hepatitis media and was given antibiotics. She presented again today with persistent fever and new onset dry cough, red eye, and rash on the face and trunk. What is your most likely diagnosis? Excellent. So measles is also one of the probably medical emergencies that we need to identify. One, because it could be some complication that happen related to the measles, especially in adults. The second thing is because of the highly infectious virus. This is a very, very infectious virus. So we may need to initiate post-exposure prophylaxis in the household contact. So fever and rash, remember sepsis, meningococcemia, infective endocarditis, Rocky Mountain spotted fever, 10 or travel-related infections, and the duration of the relationship of the rash to the fever is also very important, and this is something that you really need to remember. So varicella within the first day, scarlet fever within the second day, smallpox, which is already eradicated within the third day, measles on the fourth day, and dengue in the sixth day. So it's very important to see in the question the clear timing of the fever and rash. This is very important. I think I am going to stop here. لأنه it's already يعني 9:30. There are other questions, like I think I covered the bulk of the infectious disease question that you may have in the exam. The most important fungal infection, viral infection, bacterial infection, we spent a very long time today discussing them. So I hope I covered most of the areas that could be potential questions for the infectious disease for the exam. And I don't see any questions here. Are we done? Do you have any questions?
Few questions, but I don't think they're specific. The difference between the types of leprosy, why D not B? I cannot recall the question honestly in the slide.
الكويشن لأنه كان مكتوب if I remember correctly إنه كان في a lot of acid fast bacilli. So in the lepromatous leprosy, it is, or in the tuberculoid leprosy, it's supposed to. So here, the biopsy reveals multiple acid fast bacilli, and what is your diagnosis? As I showed you here in this slide, the lepromatous leprosy has a lot of acid fast bacilli in the biopsy. بينما tuberculoid leprosy is what we call them posi bacilli. يعني number of bacilli اللي حتكون موجودة extremely low, if any. And that's the reason for the answer. Okay.
There was a question about COVID in the exam.
COVID in the
any...
exam.
Yes.
I think the questions that may come from COVID اللي هي الفاكتس اللي we know so far. أول fact هي isolation droplet. When do we need اللهم صل على محمد airborne لما يكون في aerosol generating condition, so intubation, bronch, non-invasive mechanical ventilation, هذه اللي we need an airborne isolation. Another fact that we know about COVID is the dexamethasone, 6 milligram dexamethasone for the treatment of patients who develops hypoxia. They started to be hypoxic, decreasing oxygen saturation less than 92% على room air, requiring oxygen supply. We know إنه dexamethasone decreases mortality. The other thing that I think is also important إنه سألوكم عن activity of all the repurposed drugs, hydroxychloroquine, chloroquine, هذه كلها does not work. خلاص, by evidence based, these are all out. The other thing that I think may come in the exam is the effect of the vaccination على pandemic. We think the only way to go back to normality هو vaccination. They may ask you about mitigation measures or what should we do. I think vaccination. I think outside هذه الpoints that I mentioned, في الكوفيد we are still learning. صح, it is one and a half year pandemic, لكن هذه I think these are the things اللي very well we can call them solid facts ما حتتغير in the near future. الباقي كله بيتغير with time.
Okay, Doctora. Yes, in travel diarrhea, can we give lopramide?
In what, sorry, معلش?
In travel diarrhea, in traveler diarrhea.
Yes, we can. Yes.
Okay. And alone without antibiotics such as Cipro or azithromycin?
Yes, لأنه it can be self-limited. So symptomatic treatment can be enough.
Sure. There was a question, I think, when you were going through the HIV part. What about iris?
Iris, I think this is a bit I think it's not an internal medicine board question. I think it's more of an ID question. Like in general, iris happened after 4 to 6 weeks of initiating antiretroviral medication. Two things could happen. One, if the patient has an opportunistic infection, you could see worsening of the opportunistic infection. Like the patient will look good, and they will not look sick, and they will not be continuing to lose weight or whatever. They will look okay. لكن مثلا for cryptococcal meningitis they may have an increase in their intracranial pressure. This may cause headache or decrease in level of consciousness. The second thing that could happen with iris was unmasking of an opportunistic infection that you did not see initially. So for example, a patient who had UC retinitis, you did not see it initially. Patient did not complain, you did not send the patient to ophthalmology, and now 4 to 6 weeks into antiretroviral, and now they are losing their vision or complaining of visual changes. Because now with the improved immunity, we can unmask an opportunistic infection. Treatment is usually steroid, but I don't think they will ask you about the treatment.
And there was a question about prophylaxis for how long, 21 days, but I'm not sure in which part this question came up.
Prophylaxis for what?
Yes, and this is COVID. What's medication decrease mortality in COVID-19?
Dexamethasone, 6 milligram.
Okay. COVID mechanism or receptor, ANS receptor?
No, I don't think. يعني الباثوفيسيولوجي حيسألوكم عن ACE1 ممكن. لكن I really don't think this is a material for a board exam at this time. And we are still learning about the pandemic, and I think the most important thing اللي هم they need physicians to understand infection control measures and vaccination. I think these are the most important 2 points that the country now is trying to force or to show people. You know, these are very, very important. Mitigation measure اللي هي social distancing, masking, vaccination, very, very important. Plus, how vaccination will help the countries to go back to normal. I think these are the most important things in COVID. المفروض صراحة لو جاء exam COVID يكون هذه الأشياء.
Dr. Fi can question the 14 years old boy in the isolation part where infection control part where the answer was droplet precaution. They're asking about the diagnosis with a whitish gray adherent membrane and the tonsils and uvula and soft palate.
دقيقة
brain bleeding.
Corynebacterium.
Okay. Fair enough. I think any more questions? Prophylaxis post suspected HIV exposure.
Prophylaxis post suspected HIV exposure until the finishing of the workup. So, and I mentioned it, I think, in the slide. So if you are going with the, I think I mentioned it here, if I'm not mistaken. Yes. If you are using the 4th generation antibody testing, then at 6 weeks, you could potentially be sure انه this patient does not have an HIV. احنا we usually give 4 weeks 28 days لحد ما تطلع الريزلتس حقت ال HIV viral load and or the combination test. لكن usually the WHO recommendation goes with 28 days. If you are able to do HIV viral load, let's say after طبعا ال HIV viral load ما يطلع positive في circulation إلا يمكن after 3 to 5 days من infection. So if you do 5 days viral load في recipient في exposed person and it's negative, then potentially ruled out HIV, so you can stop it. Like most of the recommendation or most of the exam question حتكون based على WHO recommendation that says 28 days.
Okay, and there's a question about malaria. Is the SP antibiotic contraindicated in treatment of malaria in a patient with G6PD because it could exacerbate hemolysis?
Yes.
Okay. One more question. There was a TB question where treatment was 2 months of quadruples and 5 months of INH and rifampin. Okay.
This is probably the pregnant lady. Now, there are two schools. The WHO does not recommend streptomycin for the treatment of HIV, sorry, not HIV, pregnant TB lady. CDC says an streptomycin can be used or pyrazinamide can be used. I think most of the questions will go most likely يعني البورد question حتكون based على WHO recommendation. WHO recommendation recommends omitting البيريزيناميد يعني 3 agents والquestion كان 3 agents ما كان quadruple for 2 months and then giving for the other 5 months يعني total duration of 7 months with the INH and rifampicin. هذا based على WHO recommendation.
I think no more questions, Doctora. Thank you so much for your time and this informative 2 lectures. We really appreciate it. Thank you so much.
Thank you. إن شاء الله.
الله يسعدك دكتورة. شكرا لك. Okay, for all the audience, we will send the handouts of Dr. Reem's lecture by tomorrow, inshallah. You will receive it from the ATA. Tomorrow, both lectures of gastroenterology will be also recorded, inshallah. And see you all tomorrow at 5. Any questions for us, organizers? Okay. Thank you so much. Assalam.